discussion about the perioperative care concept in complex SIM. There are three phases of the surgical procedures related to perioperative care. The first is the preoperative phase, the second is the intraoperative phase, and the third is the postoperative phase. And we're going to talk about each one of them as we go. Let's talk a little bit about the interprofessional team. The interprofessional team is made up of a large number of people. I've narrowed the list down a little bit, but in your book it talks about several other people that are available to help as part of this interprofessional team. Ones we're going to be talking about today and focusing on is the surgeon. The surgeon is the one who makes the decision that this person is a candidate for surgery. You have anesthesia. Anesthesia is the one who provides the anesthetic or things that help the patient to be more comfortable during the actual surgery. This person can either be a physician or it can be a nurse practitioner. Let's see, you have a pre-op nurse. The pre-op nurse is the person that does a lot of the pre-op education, does the preoperative history and physical, and we're going to talk about her role a little bit more as we go on. The circulating nurse is the person that works in the OR and is the primary documenter and overseer of a lot of the care that goes on with the patient in the OR. You have the surgical tech or the surgical scrub, and this person is someone who handles all of the sterile parts of the surgery itself. They pass instruments to the physician. They help with any of the techniques that need to be done. They help collect specimens, those kind of things. The first assist, in the past few years, we've had where nurses can actually do an extra certification. They take like an extra bit of time and education, and they learn how to do things like suture and put staples on, and they're there to help hold instruments and be like that second person for the surgeon. Then you have your postoperative nurse, who is the individual who receives the patient after their surgery is completed and they're moved into the recovery room. So there are some perioperative diagnostics that are done that are pretty routine for any patient that is going to surgery. First would be your BMP or your basic metabolic panel, which gives you a baseline for your electrolytes. CBC would important to look at that would be your hemoglobin, hematocrit, anemia, platelet count, things like that to give you an idea of what the baseline is again. So we can determine if there's been any bleeding. Postoperatively, then we can do transfusions if we need to. Your PT, PTT, and your bleeding time will give a good indication of whether this is this patient's ready to go to surgery, or if we need to do some kind of intervention so that we have a better control of their bleeding status while they're in surgery. Arterial blood gases are sometimes done before surgery, even during surgery and after surgery, when we're concerned about some of their respiratory statuses. If it's a woman that is childbearing years, then we like to make sure that we get a pregnancy test before we take them to surgery, because you have the risk of anesthesia. You have, if there's any x-rays or anything that's taken during the procedure, we want to make sure that they're not pregnant and that we're not causing potential harm to a fetus. Chest x-ray is pretty standard to determine, again, this gives you a pre-op baseline. You can do one before surgery, you can do one after surgery to see if there's any difference, and an EKG. Chest x-ray and EKG are typically done, institutions have different ages where it's done routinely. If you're over the age of 55 or 60. It's kind of done on a routine basis. Again, so it's to make sure that we don't have any underlying problems that need to be addressed before we have the surgical procedure. So there are some very common perioperative medication classifications that we're going to look into right now. And the first are your antiemetics, which are things like metoclopramide, Reglan, ondansetron, which is your Zofran, dexamethasone, which is your Decadron, your non-opioid analgesics such as IV acetaminophen, anxiolytics, which are Versed and Valium, opioid analgesics. Commonly, we see morphine, fentanyl, hydromorphone. Of the three of them, probably hydromorphone is the most commonly used now. General anesthetics, the only one I'm listing here is the propofol, but there are other general anesthetics that are used. And antibacterial drugs such as your cephalosporins, your aminoglycosides, and sulfonamides. Some examples that not generic, but trade names that you might be familiar with are things like Ansef, vancomycin, penicillin, levofloxacin. So now that we've gotten a little bit of the more common things that you see throughout perioperative care, let's start with looking at the preoperative phase. Now, this begins when the patient is identified as a candidate for surgery or some other procedure. The patient is assessed and is prepared for surgery, and during this time is when they get their lab tests done. We do any of their pre-op lab work or other diagnostics, and their medication administration is done before they go down for surgery. So the first part about preoperative nursing that we're going to discuss is preparing the patient. And this involves a lot of the education about what's going to transpire during their time when they're having the day that they come in for their surgery, what they might expect when they go down to surgery, and what they might expect postoperatively. We're also looking at and reviewing what their history is. So we're going to do a nursing history and physical. And during this time, we talk about different things that, their past experiences with surgery. And again, this is just to establish a very good baseline so we have a good understanding of what this patient has experienced in the past and what we might be able to expect from them as they're going down for surgery. We also review any of their current medications that they're taking. And primarily, this is to give us a good idea of some of their background, again, to set a baseline for us. One of the things that we really want to talk to them about are some of their over-the-counter medications and herbal supplements that they take, because some of those over-the-counter medications and herbal supplements can thin their blood, make them more prone to bleeding, or cause other potential problems. This is also where we witness the signature on an informed consent. As the nurse, we are not obtaining the consent, we are only verifying the signature. This informed consent is required for the surgery itself. It also includes a consent for anesthesia and the administration of any blood products should they need them. And so what I've included here is just an example of an informed consent, and you can see that it includes surgical operation, any invasive procedures, the date of birth, the patient's name, and then it talks about I consent to surgical operation / invasive procedure, and it tells the name the name of the patient, authorized to perform whatever procedure it is. And with the consent like this, when you're getting that signature on it, there can be no abbreviations for the procedure that they're having. It has to be totally written out because that's part of one of the legal parts that we have to do. You'll notice that this also includes that they have been explained general anesthesia or sedation, regional anesthesia or local anesthesia. And again, this is just a little bit of an idea of what an informed consent form looks like. So one of the roles of your pre-op nurse is to do your pre-op assessment. And some of the pre-op assessment data that we're trying to collect include this big long list of uh, things that we're going to look at on a little bit more individual basis. We look at allergies, and this is really important when you've got this person that's going down, they're going to be under anesthesia, they can't really speak for themselves. So we need to make sure as nurses that we are very clear about, do they have any allergies to any medications? Do they have allergies to latex, seafood? Those kind of things are iodine. They're really important before they go down. So that's one of our jobs as a pre-op nurse is to get that information. We want to talk to them about previous surgeries. This is important in that it can show some of their reactions to anesthesia, if they had any, what kind of anesthesia they had. Can also give you an idea of maybe there might be some complications for the particular surgery that they're going to have now. Want to look at their personal or family history with anesthesia. Again, this is just to give you an idea of what the anesthesiologist might be able to expect when they go down there. If they've had no problems with it, great. But maybe with the anesthesia, they always get really nauseous afterwards. And what that gives the anesthesiologist information so that he can medicate the patient so that when they're in the post-op phase, they're a little bit more comfortable. Do they have any hearing aids? Do they wear glasses? Do they wear contacts? Now, contacts need to be taken out before they go down for general surgery because their eyes are typically, if it's a long surgery, they'll tape the eyes shut. Contacts can dry and get stuck in the eyes. Glasses and hearing aids. Sometimes they'll allow the patient to wear the hearing aids or the glasses down until they go into the procedure. Imagine if you cannot hear or you cannot see or both when you're going down and they're trying to explain things to you or trying to ask you questions and you've had a couple of your senses taken away from you. Do they have any loose teeth, any crowns, any dentures? Typically, dentures are taken out before people go down for their procedures because they could get lost down there. But if they're getting general anesthesia, they're going to be intubated, and if they have loose teeth or crowns, we want to make sure that we're aware of that so that we don't lose the teeth or interrupt any of the crowns that are there. Do they have a pacemaker or do they have a prosthesis? Important to know, especially when they're doing positioning or again, it's an implanted device. You'll be able to see if they have a pacemaker with pacemaker spikes once they're on the EKG downstairs being monitored. But you want to make sure that you've made that abundantly clear that that's what's going on. You want to verify their NPO status. Now, when was the last time they had something to eat or drink? Really important because if they had a light breakfast before they came in, then they probably will not be going down to surgery first thing in the morning like we anticipated because we really don't want them to have had something to eat. They go down there, we go to intubate, then they end up aspirating and we end up with a worse problem than when we started. Do they have any retained hardware or metal? Again, this is related to being down in the OR and they use different equipment down there that this retained hardware or metal may have an impact or a bearing on that, so it's good to know. Have they had an assessment for deep vein thrombosis? Do they have poor circulation? Should they be on sequentials before they go down there? So we have to look at those kind of things. We also want to look at a cultural assessment on the patient. People of different cultures respond differently to the surgical environment. They respond differently to pain. And so it's really good to know how that's going to work for them based on their culture. Communication assessment. How does this person communicate most effectively? If they have hearing or seeing or vision disturbances, then we need to take that into consideration and maybe put their glasses on as they're waking up from anesthesia so that they aren't so disoriented when they're waking up. And it's also really important to do a drug and alcohol assessment. How much do you drink? When was the last time? Or do you do drugs? Because that both of those things can have an impact on how you respond to pain management while you're down in the recovery room or post-operatively. So one of the things that we do as a pre-op nurse is complete a preoperative checklist. Now, this is just one example of a pre-op checklist, and it's kind of specific to whatever institution that you work in, but mostly the information is very, very similar. You can see on here the pre-op requirements where we talk about height and weight, any allergies, vital signs, is the history and physical on the chart, is it been within 30 days? Is it signed? Is there a signed and witnessed informed consent? And is there a signed consent for blood administration? Type and cross, was that done? Any diagnostic results? And you can see these are very similar to what we talked about as some of the common diagnostics that we're looking at. You have your hemoglobin, hematocrit, your PT, PTT, chest x-ray, EKG, any other labs, and if there was a final chart review. Now that's done as a pre-op. On the day of surgery, you can see where is the surgical site marked? Is the ID band on? Is the allergy there? A set of vital signs and what time you took them. How long they've been NPO. Let's see, was there a preoperative skin prep? And what did that involve? Makeup, nail polish, false fingernails, false eyelashes, were they removed? Hospital gown applied. Valuables, yes or no? And you can see where it talks about dentures, wig or hairpiece, eyeglasses, contacts, hearing aids, prosthesis, jewelry, clothing. One of the things under valuables, you want to ask about piercings. Do you have any piercings that I cannot see, and did you take them out? Really important because of the cautery that they use downstairs. Disposition of the valuables. Did they go home with a family member? And did you give any pre-op medications and what times? This is a very common pre-op checklist.